Hello, and welcome to Caregiver Action Network's seminar, Families and Schizophrenia, Earlier Engagement, Bigger Benefits. I'm John Schall. I'm the Chief Executive Officer of Caregiver Action Network, and we hope that you find today's webinar to be useful. We're going to concentrate on schizophrenia as an illness and the challenges that family caregivers face, and why it's important for family caregivers and family members to engage as early as possible in the schizophrenia diagnosis. During these 90 minutes, you will hear from three very terrific presenters, giving us organizational and personal experience that I think will be helpful to all of you. And also, you'll have an opportunity at any point during these 90 minutes to ask us questions that we'll hope that we'll have time to answer when we get to the end of the webinar. So please feel free at any point during these 9 minutes to type into the chat box function on your computer, which may be on the right-hand side, or if you're using a phone, it may be a button on the bottom, to put your questions in. Also be assured that if towards the end of the webinar we don't have time to address all the questions that come in, we will get back to you directly and respond to some of your questions. As I said, I'm John Schall of Caregiver Action Network. Caregiver Action Network is the nation's leading consumer-facing nonprofit organization that serves family caregivers across the country. There are 90 million family caregivers across the country, and we try to provide resources, education, and support for them free of charge. Because we are here as the organization that helps family caregivers, we wanted to talk today from the family caregiver perspective about mental health challenges, specifically schizophrenia. We know that mental health challenges affect the entire family and are hard on everyone in the family, and not just the patient. We work with family members across the country, and of many of those who are affected by mental health concerns. So we know from what they tell us that there are real barriers that get in the way of family members seeking answers to the challenges that they face and trying to get the help that they need. With schizophrenia, it gets even a little bit more challenging, because oftentimes the patient may even refuse to have a family caregiver at all. Certainly there are family members there, and there may even be a primary family caregiver, but as many of you know, as the illness progresses, sometimes the loved one can simply push the family away, insisting that they can manage their own issues. Today's theme is the value of early engagement by families of loved ones with schizophrenia. What we want to get to in the course of this 90 minutes is as much help as possible from you, for you, and to hear from you on how families can engage early, because we know early engagement can lead to better outcomes. There's no question that treatment for schizophrenia and other severe mental illnesses that are started before one or more schizophrenic episodes will have better outcomes in the long term and down the line. There even may be treatment options that family members don't know about right now. Certainly everybody is aware of pills that can be taken on a daily basis for schizophrenia, but there are other treatment options as well. For instance, long-acting injectables that can be taken on a monthly basis, and even maybe last longer than 1 month or up to 3 months. So there are other options available to families. At Caregiver Action Network, we wanted to get into the mental health landscape and try to help families because we've been getting questions and concerns from families across the country. You see 2 stories here as an example. One is a caregiver for their 20-year-old son, and she wonders what she can legally talk to his psychiatrist about, those privacy concerns. Another situation here, a man's wife who's really been battling mental illness all of her life, and he's really wondering how he can be engaging in the right conversations with her doctors that gives the right input, because he has an insight and has an observation for her situation. Another couple of stories here you see a woman caring for her dad who's bipolar, using several medications, always wondering how she can be more helpful in managing the medication regimen for him. And then someone whose younger sister contemplating suicide, various medications, often gets really bad. Both parents are now gone, so this sibling is really in charge of this younger sister. Certainly it gets exhausting. Where can she turn to for help and really just kind of vent some of the emotions that come up? Because of those questions that we've been receiving from across the country, Caregiver Action Network, about a year ago, launched a resource that we would like to tell you about here today. It's called Blueprint. Blueprint for families of loved ones with mental health issues. Blueprint was a website that we launched a year ago, really designed for family caregivers of loved ones dealing with mental health issues. You can find it at caregiveraction.org/resources/blueprint, but don't feel like you have to memorize these URL sites now. We'll show them again at the end of the webinar, and certainly you can always reach out to us and we can point you in the right direction. Blueprint for us, we wanted to address 4 major areas that we've been hearing from people about. How to support your loved one in monitoring their medication regimen. Secondly, privacy issues, because I think we're often discovering HIPAA may not be the barrier you think it is to having conversations with the healthcare professionals who are treating your loved one. And then when you have those conversations, some useful tips for discussing the mental health issues with your loved one's doctors. And then finally, perhaps every bit as importantly as all the others, the ability to connect with other caregivers of loved ones with mental illness on our online caregiver community, where you can talk anonymously, get tips and advice from others, and just vent when you need to vent. Another extremely useful resource I'd like to tell you about is something called choicesinrecovery.com. Choicesinrecovery.com is a website that was put together, made possible by Janssen Pharmaceuticals, which is also made possible today's webinar. It's an extremely useful website. I will say I have gone through every page of this website myself, and there are so many topics in here that are worth exploring. Understanding treatment options, how caregivers matter, recovery plans, and a lot of very useful worksheets on how to make decisions together. So please go to choicesinrecovery.com to understand some of that and be able to use it. As I said at the outset, we are going to have 3 terrific presenters today, and I'm going to start introducing them. And before I do, let me just give a reminder again that we do want to be able to address questions from all of you. And so certainly please chat in the chat box and give us your questions at any point during these 90 minutes, and we'll be able to discuss them. Our first presenter, I am just so pleased to have my friend Paul Gianfrido, who is at Mental Health America. He is the President and Chief Executive Officer for the last 5 years. I will say since Paul took over 5 years ago, he has emerged as such an important leader in the mental health landscape. He's interestingly also a former state legislator, a former mayor, a blogger, and a writer on these issues. So here's a person who's able to talk about these very important issues from the standpoint of a national organization, from the standpoint of a government, from the standpoint of a policymaker, and from a personal standpoint because of his experience with his son, Tim. So thank you and welcome to Paul Gianfrido of Mental Health America.
Thank you, John. I'm really pleased to be able to do this with you today and to share some of my insights and my experiences with some of the other people who are on this particular webinar. Let's start the slides that I've got, and I've got just a few that I want to go through with folks here, and they'll be self-explanatory to some extent, but also I think help people get a sense about the kinds of issues on which we're working here at Mental Health America and on which I'm working in general in the course of my own life. One of the fundamental issues that I think we need to recognize is that as a matter of public policy, we have been trapped in what I call stage 4 thinking for way too long. By applying this danger to self or other standard as a trigger to treatment, we've made mental health conditions the only chronic diseases in America that we've waited until stage 4 to treat, and then often inappropriately only through incarceration. And at Mental Health America, we believe that that has to end, that we have to act before stage 4 And we have made the concept of action before stage 4 part and parcel of the work we've done over the course of the last 5 years and will continue to do in the future. And as such, what is fundamental for me as we move upstream is not just that we move to address crises and not just that we move to address the immediate concerns that may exist before crises, but that we begin at the earliest possible stages with earliest identification of issues that we possibly can have. Let me explain why throughout the next slide. So here's the problem that I've experienced as a parent and that too many other people who have loved ones with schizophrenia are experiencing. My son, Tim, who is now 34 years old and living in San Francisco, first showed signs and symptoms of what would be diagnosed as schizophrenia when he was 5 years old. On the cover of the book that I wrote, Losing Tim, How Our Health and Education Systems Failed My Son with Schizophrenia. Tim is not unusual. Half of mental illnesses emerge by the age of 14, 3/4 by the age of 25. So we're often seeing the first signs and symptoms of serious mental health conditions when our kids are kids. And we're losing far too many of our children. We lose them, as in the case of Tim, to these signs and symptoms of illnesses that could be treated while they're school children, but aren't effectively treated that way, in part because they aren't effectively diagnosed that way. Tim showed signs and symptoms of schizophrenia when he was 5, but he wasn't diagnosed with schizophrenia till he was 16 years old. We lost 10 years of opportunities to intervene appropriately, while we as parents had questions and concerns and worries and anxieties that just were never addressed. And I might say that it was tough on us as parents, but it was not nearly so tough as it was on Timothy, who never finished another year of school on time after 5th grade, despite the fact that he continued with his education until he was 18 years old. And at the time he left his final high school at the age of 18, unable to graduate, his reading skills had improved dramatically, but his math and spelling skills were no better than they were in the 2nd grade. In addition, Tim tried to move out on his own when he was 18, but he was repeatedly evicted from housing that we found for him when his symptoms flared up. He wanted a job, but he was fired when his symptoms flared up and was never employable by today's standards again, even though Tim would love to have a job. And while Tim did not want to get trapped in today's revolving door of occasional hospitalization, frequent incarceration, and chronic homelessness, that is what happened to him too frequently during these past 15 years and what has happened to so many people like him. We know where he is when he's in jail. We have a sense of what we need to do to try to keep him housed, but every time he's evicted, we have to figure out again where he is when he goes on the streets and figure out with him ways to get him back off the streets. And it's all too common a story. Let's go to the next slide. Now, Mental Health America, as I've mentioned, we've tried to move upstream as a response to this because people ask me, what is it that we can do for Tim? What I often tell people is at the age of 34, Tim doesn't really want much of anything from us. But if you asked him when he was 5, if you had asked us when he was 15, there were plenty of other things that we could have done for him. And early identification and then earlier intervention starts for me with screening. The U.S. Preventive Services Task Force recommends regular mental health screening for everybody over the age of 11. For kids, it should be as common as vision screening and hearing screening. For adults, it should be as common as blood pressure screening, yet few of us get these regular mental health screens every single time we have contact with the healthcare delivery system. So at Mental Health America, what we did 5 years ago was to put some of our resources where our advocacy was, and we put online those 9 screening tools. And more than 3,000 people a day come and complete a screen. Over 4 million people have completed a screen to date, and they have been telling us a lot about what signs and symptoms of early mental health conditions, early mental illnesses like schizophrenia are. Next slide. So here are just the results from the last 2 years with 2 million screens completed. 73% of the people who take a screen as positive or moderate to severe. Fully 3/4 of those who screen. Let's go to the next slide. Of the people who take a screen, 2/3 of those people tell us that they have never been diagnosed with a mental health condition before. 3/4 of those people are under the age of 25. But what I want to focus in on for the last couple of slides here are what people who self-identify as caregivers have been telling us as they take a mental health screen. Well, they mostly screen for post-traumatic stress and for substance use disorder. And we moved a little quickly through that slide there. So I don't have opportunity maybe to continue to cover the last 4 points on that slide. But can we go back? There we go. They're more likely to want to take the next steps of people who are screened. They are more likely to report having a comorbid health condition of some kind. Nearly 40% report that, and they themselves are more likely to have been diagnosed at some point in the past with a mental health condition. Half of them, in fact, have been. Now let's go to the next slide and take a deeper dive into those data around the caregivers who take screenings at Mental Health America. They are most frequently positive for post-traumatic stress and depression. But look at what the 112,000 caregivers have told us in terms of the other conditions that they have. We often think, when those of us are talking about schizophrenia, for example, that we're talking about people who don't have schizophrenia, taking care of people who've got schizophrenia. But our caregiver population cuts across all groups, and in fact, a considerable portion, 81%, of the caregivers who take a screen for psychosis, which would be the closest screen for schizophrenia that we offer, 81% of them have, in fact, and are positive for psychosis. So many of the people who are giving care to other people, who are giving care to their children or care to their parents, themselves have schizophrenia. But the overwhelming majority of people who screen for any condition, PTSD, depression, anxiety, alcohol or substance use, or bipolar, as caregivers, they are positive for those particular things. So those of us who have experience as caregivers, and I think that's the final slide that I've got here, if we want to take the slides down for a minute. Right, I think the vast majority of us who are caregivers ourselves experience significant mental health concerns and conditions. And if we are going to get the maximum help for ourselves to enable us to give the maximum help to those people for whom we're caring, we need to identify those conditions and concerns for ourselves early on, and we need to address them early on. So it helps us to do that for our kids or our parents and the other people for whom we are providing this assistance, but it also helps us do it for ourselves. Now, I want to close with just one little anecdote related to Timothy. So, Timothy, unfortunately, got his condition very early on in his life. So nearly his entire conscious life, he's lived with schizophrenia and the symptoms of schizophrenia. And any parent knows that the childhood with kids like this can be extraordinarily challenging. On one of those particular days, I was talking with Tim, probably he was around 10 or 12 years old. And I said to Tim, I'm doing all this caregiving for you now. I'm taking care of you now when you're a kid, but remember, when you're a grown up and I'm old, then you're going to have to take care of me. And he looked me in the eye and he said, Dad, I'm going to put you in a home. And that was it. So good for Tim, who has maintained that sense of humor throughout his entire life. With schizophrenia, you just have to have a sense of humor sometimes. Thank you.
That's wonderful. That's wonderful, Paul. Thank you so much. Before you get put in a home and before I bring in the next presenter, I actually do want to ask you a question, because I was just so intrigued by those numbers that screening the caregivers and what they are facing. I mean, that's just an extremely compelling story that the caregivers are in many ways suffering themselves of so many things, depression, PTSD, etc. Um, I know that Mental Health America, in addition to the screening tool you have for everybody for mental health, the 4 million, there's actually a screening tool for caregivers that we should make people aware of, because those numbers just aren't out there. There's a screener that people can actually use. I know we push it out from CAN. Do you want to elaborate on that for just a minute?
Yeah, I think that one of the things that the medical community may have inadvertently mystified was the notion of behavioral health screening and mental health screening being something that had to be done in clinical settings. And, for those of us who had no background, I mean, I was a philosophy major in college. So I had no background in psychology, no background in behavioral health at all. We were thinking Rorschach tests and people with highly skilled trying to interpret things that we said, but these screening tools are available. You find not only can caregivers, I mean, caregivers can take caregiver specific screening tools, but if you're going to get a PHQ-9, you go to our website, take a PHQ-9, identify yourself as a caregiver, and we can also provide some additional information that way. So I think my response to the question is maybe a little broader than it was, and that is simply that you and we together have made tools available to people that can really make a difference in their lives. Answer 9 questions and you can learn about depression. 7 questions, like me. I was diagnosed at the end of my caregiving time with generalized anxiety disorder. The GAD-7 did that. 7 questions a clinician asked me after an anxiety attack that determined that was what had affected me after 20 or 25 years at that point of caregiving. So John, I commend you for what you're doing and for bringing this to light. And I think all of us need to recognize that we live, many of us, with behavioral health conditions that we're ignoring because we're trying to take care of other people. And the best way we take care of other people is first to take care of ourselves. And that's our behavior, our own mental health. That's setting our own boundaries, our own understanding of what we can manage, and then moving forward from there.
Thank you so much. We will bring towards the end. Pleased that she could be with
Hi
us
there.
from Wisconsin. Hello, Krista. So Krista Hickey is from Wisconsin. She is a blogger and mental health advocate who really specializes in providing education and support for parents of children diagnosed with serious mental health conditions. Krista has a tremendous reach, and she's done such wonderful things. Actually, back in 2011, she was recognized as a mental health hero. But one thing that I think is just wonderful, she cares for her son, Timothy, who has
another Timothy.
Yeah, another Timothy. And what I think is just so great, before I let Krista talk here, is Tim was selected as one of 11 heroes of 2011 by ABC News.
Yep.
So I just think that's an amazing story. So Krista, thank you for being here with us from Wisconsin. Welcome.
Thanks.
And Krista Hickey.
Thanks for having me. I just thought I only have a couple of slides. I'm not a professional, so I'm just a parent like a lot of other caregivers. So I thought maybe I could tell you a little bit about me and my son, Timothy. First off, with the first slide. If we can bring that up. There we go. So this is my son, Timothy. When he was first diagnosed with we knew something was up, let's put it this way, when he was about 18 months old. We weren't sure what it was. Tim is our second child. We have an older son. But by the age of 5, and this is a picture of him when he was 5 years old, he was diagnosed with an emotional disorder not otherwise specified. I soon grew, like many caregivers of children, to really detest the NOS label, because typically NOS means we have no idea. That's what we found out as parents. And Timothy's symptoms became a little more evolved, and to the point that they were easier to identify as a particular type of mental illness by the time he was 11. So he went through several different diagnoses, the EDNOS, then he went to bipolar, not otherwise specified, then bipolar type 1 with psychosis, possibly schizoaffective. At the age of 11, he attempted suicide for the first time and ended up in a psychiatric hospital, children's psychiatric hospital, for 45 days. And at that point, he was definitively diagnosed with schizophrenia, and that has stuck with him throughout his life. Tim will be 25 years old next month. So it's been quite a long road for us, from 18 months, 2 years old to 25, obviously. As you've heard from the first speaker, of course, raising a child with a severe mental illness throughout those childhood and teenage, those adolescent years, can be hell on earth. And if you've raised a child that started showing those symptoms around that time, you know what we mean. We would vacillate between getting him on a therapy or a medication that seemed to be stabilizing him, and then having him go through a growth spurt and it doesn't work anymore, or just the hormones combined with what was going on with his symptoms could make him very violent. Timothy was actually removed from regular education programs and put into non-public special schools by our school district in the second grade. But by the time he was in the 8th grade, he was on his 7th non-public school. He'd been asked to leave several of them because the symptoms were too much for them to manage. A lot of time, these schools were used to dealing with children that had autism or an autism spectrum disorder or some type of depression. But Timothy, in his psychosis, obviously could become very violent. And things like at the age of 6, he managed to pick up a child's desk, the one with the chair attached to it, and literally put it over his head and throw it at a teacher. So we were dealing with that kind of expression of rage for him. And typically that was his expression of not understanding what was going on in his own head. Between the ages of 11 and 18, he ended up having 16 inpatient stays for over 300 days. And after that, he spent 4 years in a residential treatment facility here in southern Wisconsin, which actually was the only way we were able to get him stable. They did a really good job of managing his symptoms, working with us and their psychiatrist on staff to manage medication for him. And by the time he was not quite, almost 19, he was actually discharged from residential treatment and came back to living at home. So he spent from the ages of 15 to almost 19 in a residential treatment facility. When he did come home, we went through some of the same things the earlier speaker talked about with his son, Tim. Tim, his reading skills managed to progress somewhat. I mean, while he was in a residential treatment facility, he did attend a school. However, the emphasis was really on getting him to be able to manage how education in very small chunks, because he couldn't manage sitting in a school desk all day long. He reads at about a 7th grade level today, which is much better than he was even at 18. He was much lower than that. His spelling obviously leaves a lot to be desired. His math skills leave a lot to be desired. And he went to the public school by us until, as what they call a super senior. Basically, he aged out of the school district the day before his 22nd birthday and received a certificate of completion, but technically he's never really been able to graduate from high school. My husband and I didn't know what to do when you're trying to raise a child who has a severe illness like this. In fact, we first questioned the psychiatrist that diagnosed him with schizophrenia, because we had never heard of a child being diagnosed with schizophrenia. So by 2009, early 2009, in my search for answers and other people maybe that are going through this to get some feedback, I started a blog, and I just very easily started cataloging our lives with Timothy, what was going on. And I kind of found what I call my tribe, some other parents that are going through this with children with bipolar disorder and schizophrenia. And we started supporting each other for a number of different ways. One, through my blog, I've been able to meet a lot of other parents. And second, I co-moderate with a friend of mine, a support group on Facebook that has just shy of 10,000 parents in it, all dealing with children with some kind of brain-based illness, whether it's autism, a mental health issue. We even have, cerebral palsy. A lot of these things have a mental health component to them. Obviously, when you have a special needs child, a lot of them have a mental health component. So we have a very large support group that spans, I think we're in like 12 different countries right now. A couple other things I want to talk about on the next slide real quickly. So childhood onset schizophrenia, technically, if you look at the information, and this is all from the National Institutes for Mental Health, it's considered childhood onset if the symptoms and the diagnosis, and that's the difficult part, are before the age of 13. Typically, we find it's very difficult when we talk about earlier engagement, earlier diagnosis, earlier treatment. What we found is that not only is it very difficult to diagnose a child with an illness like schizophrenia when they're that young, because if you take a look at the symptoms side by side, for example, of an autism spectrum disorder, there's about a 60 to 70% overlap in the symptoms. So children have a difficult time of expressing what they're experiencing as far as the symptoms go. They haven't developed that language yet to be able to express it. So it's difficult to diagnose unless it's exceptionally prevalent, like it was in our son Timothy's case. About 100 children a year in the United States are diagnosed with childhood onset schizophrenia. So it's a small fraternity of people. There's about between 7,000 and 8,000 children diagnosed with it across the United States. And again, these are children diagnosed before the age of 13. And the other thing it's difficult to get a diagnosis for this is because there's still that stigma around mental illness and what it means for a child later in life. So for example, I hear from a lot of parents who say, my doctor won't diagnose him with schizophrenia, or my doctor won't diagnose her with bipolar disorder because they're worried about how it might stigmatize them later in life. It's a label or a stamp that will be on them forever if I diagnose them with that. And here's why that's crap, basically. You wouldn't worry about that if the child had cancer, or you wouldn't worry about that if the child had diabetes or some other severe illness. More children in this country die by suicide than every other childhood disease combined. But for some reason, our doctors are reticent, and this is again a generalization, but doctors are reticent to diagnose a child with a mental illness because they're worried about the stigmatization of that child when they become an adult. And that is inhibiting a lot of getting treatment and that early intervention. So a lot of what I do, and you can see this gap in provider knowledge and experience, a lot of what I do is working with parents on how to discuss this with their clinicians, working with clinicians on what it means to be diagnosed versus not diagnosed. That's a huge barrier for early engagement for a lot of us. Another barrier is there just aren't enough psychiatrists. There's about 8,300 practicing child psychiatrists in the United States. I live in rural northeastern Wisconsin. I'm about an hour and a half, about 90 miles away north of Green Bay, Wisconsin. So that gives you an idea of how far up I am. The closest child psychiatrist to me is in Madison, Wisconsin, which is a 4-hour drive one way. Now, yes, I am in a very rural area, but even in Madison, Wisconsin, which is the state capital, where our largest university is, the biggest city in the state of Wisconsin, there are about a dozen child psychiatrists. And this is actually where there's a medical school. So there is a gap in having enough child psychiatrists to actually treat children. So if you take a look at that, the number of kids that have childhood onset schizophrenia and number of doctors there are, most child psychiatrists have a less than 2% chance of ever having treated a child with childhood onset schizophrenia. My son Timothy's doctor, who we eventually went to for him, was down in the Chicagoland area, head of child psychiatry for a huge network there, and had never treated a child at the age of 65, had never treated a child with childhood onset schizophrenia. So for him, it was a real learning experience as well as for us. So you can imagine how difficult it is. If you're a caregiver, you already know, but for those of you that don't have children diagnosed, it can be very difficult to even get that care because it's so scarce to find. So those are the end of the slides for me. I just want to talk about that. That's what I do spend a lot of my advocacy work on, again, is educating people on the fact that severe childhood mental illness does exist. And that the earlier we can intervene with these kids and get them stable, the better chance they have for a better outcome. My son Timothy has spent a year now living in his own apartment. It's only 2 miles away, so we are not, we're a little cautious about it. He does manage to hold down a part-time job that's through sheltered work through a family friend, which is an option. But we're trying to create this normal life for him We've done some other things from the caregiver standpoint that make it easier for us to support him. And for example, at the age of 18, we became his legal guardians. That allows us to do things like talk to his doctors now that he's an adult, make sure that he can't get himself in trouble financially with a credit card or something else. There are things we can do to try and help our children. But we really need to, and I say this a lot, people think I'm crazy. We're lucky that Tim got a diagnosis so early because it gave us the ability to do this research and figure out the best way to support him throughout his life before he became an adult.
Excellent. Thank you, Chris, so much for sharing your personal story. There's just nothing more powerful than hearing from someone who lived it. Before we go on, though, I'm going to ask you a couple of questions.
Sure.
First of all, thank you for the strong points. One, that even the healthcare professionals will use stigma as a barrier.
Right.
It's just not families and patients who are facing the stigma. It'll even scare off the healthcare professionals. And so thank you for making that point about this is a condition like any other.
Right.
And early diagnosis gives us a chance to get in there, manage, and treat. So thank you for that point. And also for the reminder for everybody that for age 18, you do have to go through legal guardianship. They do become, adults.
Yep.
And without legal guardianship, you can be in a situation you don't want to be in.
Right.
But a couple of questions. You mentioned with Mindstorm and 10,000 people who are part of that. What is kind of the most common question or concern you're hearing from those families who are facing this challenge?
There's probably two that come to mind as the most common. The first one is worrying about medication and getting feedback on medication. So many medications for serious mental illness are not necessarily tested on children. So even though a medication may work for an adult with schizophrenia or an adult with bipolar disorder, it may not have the same effect on a child. So a lot of the questions have to do with, has your child been on this medication and what was your experience? Ironically, when I talk about my son's psychiatrist when he was a child, he was really great at partnering with us to be able to treat Timothy. So he would say to me, I'd like to try, X medication. Go talk to your mom network and see what they know about it. Because he really didn't have that experience of putting kids on an antipsychotic or more than one antipsychotic. So that's the first one. The second one is usually how to deal with raising a child and staying employed. A lot of the parents in our support group are single parents, either because their marriage couldn't withstand what was going on, or their spouse also had a mental illness, and so the marriage couldn't be sustained. So you've got a lot of single parents, single dads, and single moms that are in the support group and trying to figure out what is my recourse? What can I do to try and hold down a job? Or how do you hold down a job? Or how do you support your family when I've got a child who, I get a call from school once a week, or I've got all these doctor's appointments, or my child is back inpatient? How do I do that? It's super difficult. I mean, we've got a large population of the parents that we support in our group, and the parents that I advocate with. And I do go to them. I've gone to IEP meetings. I've given coaching for IEP meetings, how to, things like that for the school. Their biggest concern is they're very low income. They tend to be on the lower income side because it's very difficult to stay employed and be a caregiver for one of these children who has such severe needs. Those are the two biggest.
Yeah, very, 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 very important. Juggling your work responsibilities and your family caregiving responsibilities. Certainly at Caregiver Action Network, we are seeing that as one of the major concerns. And increasingly, it's becoming one of the biggest things we're hearing from people. So we have resources too on how to balance those two. Following up a little bit on the medication concern that you brought up, do you find that people are generally aware that there are several options when it comes to treatment? There are pills, long-acting injectables. Are they aware of those, or not so much aware that there may be options?
I'd say not so much, especially, again, dealing with the childhood onset. Like a long-acting injectable sounds great for a kid, but there's no clinical research on it yet. So doctor is reticent to try something like that on a child. we end up getting a lot of, there's a lot of different medication issues when it comes to the children. A lot of children have comorbid conditions. So for example, for an adult, you talk about comorbidity usually refers to an addiction of some kind. For children, it's more likely to say, I have bipolar disorder and ADHD, or, I have schizophrenia and autism. That's a very common combination. So how do you deal with medication when you're dealing with more than one illness and the medications don't necessarily react the same way for both illnesses? So parents are unaware of the different options available. And when they get an option presented to them, sometimes they get gun shy because they'll try something out and it doesn't work because of this comorbidity.
And just one more question before we move on to our third presenter, just because I'm so interested myself and I can't let you go without asking this. So what's the story behind Tim being recognized by ABC News as one of the heroes in 2011?
Well, he was, and I wish I had the picture for you, but so in 2011, Tim had finally started to get stable. He had been in residential treatment for a couple of years down near Milwaukee. And I was working a lot with Bring Change to Mind, which is the mental health organization founded by Glenn Close and her sister, Jessie. And we were doing a NAMI walk down there on a team that was raising money for both Bring Change to Mind and NAMI. And Timothy himself managed to raise $10,000 and actually went to a couple of programs with me in the southern Wisconsin area, Milwaukee area, to talk to people about what it was like to be a teenager with a mental health issue. And so the folks at NAMI, when ABC was soliciting for local heroes, the folks at NAMI in Milwaukee had submitted this picture of him and Greg Jennings, who was former Green Bay Packer, who actually was the honorary chairman of the walk that year. And because he was the #1 fundraiser, Tim basically spent the day walking with Greg Jennings and getting to know Greg Jennings at the walk. And when they submitted him and said, he's a great kid, here's this 16-year-old kid who tells other people about mental illness and has raised all this money for other people with mental illness, they selected him. And he's pretty proud of that. He he tends to function emotionally at about a 12-year-old level, but so he thinks that because of that and a couple other things that he's famous, and he thinks it's great. And the nice thing about it, and again, like I said, a lot of people think I'm crazy when I say he was diagnosed young. So we got the early engagement for us was something we pushed into him because he didn't have a choice to take meds and he didn't have a choice to go to the doctor. And at 11, but he will tell you now, and he talks to people all the time about what it's like to have schizophrenia. He's not, he doesn't have a personal stigma about it, which I think is great.
What a wonderful story. Thank you. And what a wonderful story that gives all of us hope. So that's just terrific. Thank you for sharing that, Krista.
Thank you.
We do have a third presenter, and I am pleased to introduce Ayla Colella from the National Council for Behavioral Health. Ayla is the National Council for Behavioral Health's Director of Practice Improvement. So here's an expert from a national organization that has some terrific resources and information for everybody. But also Ayla herself is a licensed mental health counselor. So here's a person who gets it not only from a national organizational standpoint, but really from a practitioner. And she's going to tell us a bit about National Council, but also one of, I think, the best tools out there. And it's the National Council Health Tool, which is mental health first aid. So Ayla, thank you so much for being with us. And Ayla, over to you.
Yeah, sure. Can you pull up my slides? Hi, everyone. I am, there we go. I am, grateful to be here with Carissa and Paul and honored. So thank you, John, and thank you, everyone. And John is right. I am at the National Council for Behavioral Health now as a project director and a licensed mental health counselor. But for many years, I worked as a clinician and as a therapist in provider organizations. So I want to talk a little bit today around more of the clinical pieces around early intervention and some of the resources that the National Council has that can be beneficial when we think about improving prognosis. So to sort of get us started, right? So where did we start? And I think for many years, I think the expectation of recovery in schizophrenia, there was a really low expectation. It was viewed more as a chronic disease, and the best hope is to stabilize that. It was an immense annual economic cost on the system of nearly $155 billion. And then in recent years, there has been an immense shift in mental health policy, and the view of sort of what treatment looks like on a continuum from early intervention to prevention to treatment. And sort of, I'll get into that in a little bit around what that continuum looks like. But I think from what used to be viewed as a stabilization of a chronic disease now is very much viewed as how can we intervene in these early stages of the illness to improve prognosis, and what does that early intervention look like, by what means, and from whom and to whom. So you can go to the next slide. Thank you. So what I was mentioning earlier, sort of this spectrum of mental health interventions, it goes from well to becoming unwell, and then recovering, and looking at the spectrum as prevention, early intervention, and then treatment. And if you see that little green square, it says where mental health first aid can help. I'll be talking about that in a little more detail later on. But I think what we're really focusing on here is the idea of early intervention and some of the details around specifically early intervention itself, and what are some of the tools and the resources that it would be helpful to perhaps know about. Next slide. So a little whirlwind history on early intervention. I would be remiss to talk about early intervention and not talk about the RAISE project. The RAISE stands for Recovery After an Initial Schizophrenia Episode. It was a large-scale research initiative in 2008 that looked at different aspects of the coordinated specialty care treatment module. I won't talk so much about coordinated specialty care, but I'm certainly happy to tell anyone more about it if they're interested or would like to know more or have any questions on it. But it really looked at this module and what was found through this research initiative is that not only is it important what type of intervention is utilized, but it's particularly important when. So the right treatment at the right time produces the best outcomes. And what did this do? So this was released in 2014. In 2008 is when it began. And Congress increased federal investment funding by $100 million in 2016, 2017 for the development of these psychosis treatment services. I think in 2008, if my memory serves me correctly, thinking about early intervention and first episode psychosis programs, I think there was 12 in the United States. By 2018, there is upwards of 90. So still a long way to go, but just to show you the impact of the RAISE project, and especially the federal investment. And when mental health policy shifts and federal investment is increased, the positive impact that can have on provider organizations and then in turn on the individuals. I think it seems like there's this big gap between sort of what's happening on the Hill and what happens on the ground, and it's a little bit closer than I think maybe I initially thought when I was working as a clinician in a provider organization. Next slide. So thinking about, without early intervention. So what happens when we don't intervene, or when some of that early symptomology is not caught? I'll keep this pretty quick because I know Carissa and Paul, talked a lot about this, but just the strain on the familial and the interpersonal relationships, the costs on systems and on families, poor long-term functioning, so often, and then the likelihood of maladaptive symptoms in caregivers, which I know Paul was talking about earlier. I think about prior to my time at the National Council, one of the programs that I oversaw was called Family Treatment and Rehabilitation. It was a rehabilitative program for families, a foster care prevention program. So it was a 12-month rehabilitative program wherein either the parent or the caregiver or the child was struggling with serious mental illness or substance use disorders. And, I remember specifically a family where the mother had a schizophrenia diagnosis for many years, and it went untreated for many years. And her daughter had the same diagnosis, and we were able to catch it. I think she must have been 9 or 10, and just the immense difference in outcomes of being able to catch those symptoms early and start treatment early. I was loving hearing Carissa talk about the fact that she loved that her son Timothy had that diagnosis early. I am such a proponent of breaking through the stigma, and it drives me nuts. So I just really appreciate her sharing that story. Next slide. So the National Council for Behavioral Health, I want to talk a little bit about who we are, what we do, and maybe what might be helpful for individuals to know about us. So the National Council for Behavioral Health is a member organization. So oftentimes I describe that as similar to how AARP does advocacy for the geriatric population, or the 55 and older population. The National Council for Behavioral Health does advocacy for our 3,000 plus members, and those 3,000 plus community behavioral health organizations and state associations collectively serve over 10 million adults, children, and families. So the National Council has quite a wide scope and depth in our reach nationally on the types, on providing help and assistance and improving outcomes for individuals who have serious mental illness or substance use disorders, and also working with their families and working with the organizations. Similar to what John had mentioned in the beginning, the National Council also has Mental Health First Aid USA. So for those who might not be aware, when you think about, probably many of you are aware of first aid and CPR. This is very similar, but it's mental health first aid. So meaning it's an 8-hour course where the basics of mental health first aid are discussed. And really there's an emphasis on breaking through that stigma. And collectively right now, more than 1.5 million Americans have been trained. I think they're shooting for 2 million by the summer, and we're well on our way. So the more, the better. Next slide. So the National Council, why should anyone care? What do we do, right? Oftentimes, the biggest piece that we have is technical assistance. I know when I was on the ground, if someone had told me about technical assistance, I thought it was, when IT comes in and helps you with your computer. It's a very different world and it's different language, I think, when you work at a national level. So I'm happy to explain anything or answer any questions. So technical assistance really is coming into these community behavioral health organizations and helping problem solve. So what does that look like? It might be helping formalize workflows, so more individuals can be served. It could be increasing workforce capacity, so helping understand and better manage finances so that more individuals can work there, so more individuals can be helped. We have a policy and advocacy arm. We do a lot of work on the Hill and advocating for our members, which is particularly important right now. Curriculum development. So just as an example, curriculum development that we might do, I just recently finished authoring a first episode psychosis, early intervention curriculum insert for mental health first aid. So we do a lot of curriculum pieces. And then when it says 60 plus independent projects, a community of practice, after we drafted this first episode psychosis insert within the mental health first aid model, we were able to pilot it in 7 organizations around the country, both urban and suburban and rural. I think it was Carissa who was talking about there being a huge distance between providers and having to drive hours sometimes. So what can we do? We often are problem solving with organizations that find themselves in really rural and frontier communities, and whether that is increasing outreach or whether that's utilizing telehealth, which I think is very much on the rise. And then mental health first aid, which I'll talk more about. Next slide. So similar to what I was saying before, mental health first aid is the help that is offered to a person developing a mental health problem or experiencing a mental health crisis. And it's really for non-clinicians. And it's the idea of understanding mental health first aid and to give appropriate treatment or provide appropriate support until the crisis is resolved or until clinical help or professional medical help arrives. Next slide. And then why is it important? This really goes to what Carissa and Paul were saying. Mental health problems are so common, and yet there is still this stigma that is associated with mental health problems. So often individuals may not realize how common these problems are, and they're not well informed. So they might want to help, but not know how. And it says professional help is not always on hand. A mental health crisis doesn't necessarily, and we all know this, doesn't happen at the doctor's office. It doesn't happen at the psychiatrist's office. It happens anywhere at any time. So knowing when to intervene, knowing how to intervene, how to respond. The more people that are trained, I think the more impact we can have on reducing the stigma. Similar to what was being said before, you would never have a doctor not give a diabetes diagnosis, not give a cancer diagnosis. We really want to do everything that we can on a policy level, on a national level, within provider organizations to break down that stigma. Next slide. And then so mental health first aid as a tool for early intervention. I think what our hope is, and with the creation of this first episode psychosis insert for our mental health first aid curriculum and really beefing up our schizophrenia module within mental health first aid, is that the more individuals that we train, the faster that symptoms can be identified. Mental health first aid has a teen pilot, and we also have a youth module. So thinking about early engagement and early identification and then early intervention. The more individuals that are aware of what this symptomology looks like, the faster we can get these people into care, these individuals into care. And the more we streamline access to care, the more we can decrease the duration of untreated psychosis. The duration of untreated psychosis, the DUP, has a direct correlation in research to improving outcomes. The less time someone goes untreated, the better. So yeah, I think that's the end of my slide deck. I'm happy to answer any questions, and just thank you again so much for having me on, and it's an honor for me.
Isla, thank you so much. I think the work that the National Council does is just it's phenomenal. It's so important. I have to say, I really think mental health first aid is an absolutely inspired program. I just think it's one of the best things out there, and whoever came up with that idea at the National Council before, that person deserves a huge raise or a bonus or something, because it's an absolutely inspired idea. I want to pick up again a little bit on the mental health first aid and the insert we put in for early diagnosis, because obviously that's the theme for today. I think, again, one of the reasons that early diagnosis doesn't happen too much is not only stigma, but people kind of, they shrug their shoulders. Well, what could we really do about it? And so I want to bring up the question that I sort of asked Carissa as well. Do you sense that people are aware that there are treatment options, pills, long-acting injectables, etc., and that the earlier one starts these, that the better the long-term outcomes are? Or is that still a real education point that we need to get out there to families and parents?
Certainly. So I'll answer from my perspective and from my experience as a clinician. I don't know if I can speak to like a national sort of statistics, but I think it's certainly still an area of growth. I don't know. A lot of the families that I worked with knew that there was help. I think you don't know what you don't know, right? So I think it was very difficult, and it is and remains very difficult for caregivers to understand how to navigate this system, and to understand what is out there. I think maybe they don't know about long-acting injectables or the types of medications that could be beneficial, or how medication interacts with therapy and what are the benefits there. So I certainly think that so often when we had a family come in, the question was, I know that there is something wrong. I don't know how to help. Like, I don't know where to go from here. So I think it is stigma. I think it's stigma more on a societal level. I often find that within the families that I work with, it's I just want to help my child, or I just want to see my mother get better, or stabilize. So I think there's still this element of stigma from a societal perspective, but I think oftentimes when you think about a family dynamic, oftentimes it's just how to navigate this ocean of resources and understanding that there is resources out there.
Absolutely, understanding that there's resources out there. I want to bring Paul and Krissa back in and up on the screen too, because we do have some minutes for some questions that we'd like to pose to all of you. And I will, in the meantime, mention, it's interesting, Caregiver Action Network, we were just in New Orleans in person. And actually the issue of long-acting injectables came up. There was a woman there who, her son, 18 years old, I think it was, with schizophrenia. She said certainly it was going to be a problem, really to the point of impossibility, of making sure that pills were taken every day for him. And then they discovered the option of long-acting injectables, which has just made the world of difference for her son and for her in the relationship with her son and managing and monitoring that medication. So it's just interesting that it just can be that important, and that everybody needs to know that there are good options out there. Actually, the first question I will actually send back to you, Isla, and then I'll bring in Paul and Chris on some others. But you know, Paul and Chris have talked about it from a childhood standpoint. But thinking about, you know, suggestions for early intervention. How does that come to play when the person is an older adult? Does any of your National Council curriculum speak to early intervention? You know, how to do early diagnosis when it's really an adult as opposed to a child, or at least a young adult?
Sure. So when you say adult, you're talking about older than, say, that 18 to 25
Right.
bracket is sort of what you're talking about. Sure. So yeah, a lot of the curriculum that we have in our teen module that we are piloting is geared towards that 18 to 25 bracket. A lot of feedback that we've gotten is that 18 to 25 bracket, we really want something focused for that age group specific to early intervention. So we're coming out with a higher education model, and we're trying to organize and partner with local schools and local universities to try and get as many individuals trained as possible, and have some of the individuals who work in a higher education setting or in an educational setting in general become instructors and become trained, so that they can then train others. Does that answer your question?
Yeah, it does. In fact, it brings up another aspect of it. So I do think the connection with school personnel is obviously very important, I think, at the university level. So is that the counselors in the university? And if it is it then advisable for family members to reach out to counselors to try to talk about what they're seeing, in their loved ones? Is there a connection there that helps from the family standpoint?
Yeah, I think I counselors is the first person that comes to mind. I think when we think about who we might want to engage, it would be the supportive staff in an educational environment. When thinking about a caregiver, that would be, I think, the first person. I got sidetracked. I was reading one of the questions and the comments in the chat box. But yeah, I think counselors would be the first go-to.
Great. And thank you for those of you who are putting questions and comments in the chat box, and we are capturing all of those, so please continue to do them. Paul and Chris, I want to go a bit further on this. You know, sometimes you're in a rural area, sometimes you're in an urban area, and certainly there are different challenges. And Carissa, you brought it up, and having to drive 5 hours or 4 hours to Madison, Wisconsin. But I'm sure there are other challenges that come up in a rural area as well. And Paul, on the urban side, as I recall, your son Tim is in San Francisco, but it's not necessarily all easy and a picnic in urban areas either, right? There's a lot of challenges that go on there, and you know, and even in urban areas, if people don't have, you know, health coverage or something like that, all sorts of challenges come into play. So, Paul, do you want to talk a little bit about even on the urban side that things are not exactly easy?
Yeah, San Francisco is considered to be a place where that's service rich, and you know, Tim's desire was to move to San Francisco. I have no idea why, but that, you know, we talk about, you know, letting people set their own goals. My goals for Tim were different than Tim's goals for Tim. Tim's goal was to move to San Francisco and live in San Francisco when he was an adult, so he did. And in a service-rich community, we thought, well, there'll be plenty there for him. Well, what's most often there for him is jail, really, as a service provider. He's got a great case manager, caseworker who really has befriended him. It's taken many years and many different caseworkers to have somebody who would engage with Tim that way. And I think urban or rural, that's kind of the first thing. It's where do you find a friend? Where do you find a peer that's positive influence? Not just a parent, because we believe we are always positive influences on them, but they don't always think so. And we're parents after all. So finding people who will engage as peers, it's tough in any area, which is one of the reasons why we're investing a lot of our attention and resources in virtual environments, because that's where a lot of younger people are finding those connections. But when you're looking for resources, you know, referrals to care and treatment are only one of 4 things that we find people looking for. They're looking for information, they're looking for peer engagement, and they're looking for do-it-yourself tools. And it doesn't matter whether they're in an urban or rural area, which part of the country they're in, those are consistent things that they look for. So even when we can't provide a connection to a clinician, or can't provide it in a quick way, we often can provide connections to peers to do-it-yourself tools and information education that'll help them and the caregivers. So we focus a lot of time and really a lot of our effort on that.
And Carissa, do you want to?
Yeah,
clearly
I mean,
that peer connection,
I mean,
those
we live in
do-it-yourself.
we live in a rural area right now, but we haven't always. You know, when Tim was first diagnosed, we lived in the Chicago area. And I think, I don't know if most people know this, but Sheriff Dart, who runs the Cook County Jail, which is where the city of Chicago is, actually realizes and recognizes that there's such a mental health need, and that so much of the people with mental health issues are actually ending up in the jail system, that the warden at the Cook County Jail is actually a mental health professional. It's that bad that, you know, in a rural area, one of the reasons we moved to this rural area, and we had always kind of planned on coming up here, moving this way, but one of the reasons when Tim became an adult and he was out of his treatment facility is that it's much easier to control his environment here. You know, we live in a town, our county has less than 10,000 people in it. My husband went to high school here. We have family here. There's very, you know, small businesses here. It's much easier for us to contain his environment here than it would be in a city like Chicago or San Francisco or New York or wherever, where Tim very well likely, if we'd stayed in Chicago, would have ended up in the judicial system or incarcerated, just because, or, you know, God forbid, something else would have happened to him. You know, Chicago doesn't have the greatest track record for, you know, keeping people alive when they're in a mental health crisis. So we're having different challenges here. And what I've seen after living here and helping some parents who have issues with their kids here is that, kind of like what Paul just said, the issues exist everywhere. There's a different degree of the problem, I think, from an urban to a rural setting, but the problems are the same.
And Carissa, let me stay with you for a second. And I know this is asking you to think back a lot of years here, but, you know, if you had to think about it, what's the one thing you wish you knew at the beginning of your journey with Tim? And so, and what one piece of advice would you give to a family caregiver of a loved one who just now got diagnosed?
Oh boy. Well, our journey started a long time ago. Like I said, by the time he was 18 months old, we knew something was up. I think when you're first, I remember what it was like to hear the first doctor sit down and tell us that Tim's first psychologist had sat down and said to us, Tim really needs to be in a psychiatric hospital. This won't be the last time. What I really wish would have happened is that we would have gotten a little more education on what it meant to have a mental illness. I think a lot of times, as a family caregiver, you hear about the diagnosis, but you don't know what it means. You know, I didn't know what schizophrenia was. I didn't know that kids could get schizophrenia. I didn't know what the next steps were. I didn't know what the prognosis was. I didn't know what that meant for him as far as not only his own mental health, but what did it mean for his education, and what did it mean for relationships, and what does it mean for his physical health? Because, you know, there's all kinds of symptoms that go along and side effects that go along with any kind of medication. So I didn't know any of those things, and I was left to my own devices to figure it out. So I would say to someone who's just had a family member diagnosed, start educating yourself, and don't let the professionals just give you a diagnosis and walk out of their office. I mean, find a way to get that education, ask them for a referral to a therapist, find your own therapist to talk to about it. I think Paul talked about, and several, talked about caregivers. I was diagnosed with PTSD, as was Tim's younger sister, after several years of into his diagnosis. Find a way to get that education and push. You need to be, unfortunately, a little bit pushy to be able to be a good caregiver. And again, I think it's easier to be pushy when you have a young child dealing with it. I think when you get older, it becomes a little more of, I know now that Tim is older, I find it a little more difficult for me to push his clinicians, because I want Tim to be self advocate and kind of learn how to manage his own care. But as a caregiver, you need to understand what's going on. So whether that takes a medical power of attorney or some other thing you can do when your loved one is in a good state of mind, to be able to have that relationship and understand, I'm here to help you. Signing something may actually help you when you are in a crisis later.
Thank you. I love the way you said that. It's true. You have to be a little pushy. As a family caregiver, you are the world's single best advocate for your loved one with schizophrenia or mental health illness. So, yeah, you do have to be a little pushy and insinuate yourself into the process, and learn as much as you can and be able to do it. Well, Paul, what single piece of advice would you give to a family caregiver of someone newly diagnosed?
They should pay attention to what Carissa just said. It's a marathon, and not even a series of sprints. And when it starts, we first hope it's going to be a sprint, then we hope it's going to be a series of sprints. And so there's a lot of things I wish would happen for young kids like our Tims at the time that they're young, that could be changed with better screening, with the schools, all the schools doing a better job. I mean, my Tim went to public and private schools. He went to emotional growth schools. He went to institution-based. We all have the same story, basically. And none of it really does all that well. I mean, they're kind of just managing people through the years. And I'd like to see that change. I'd like to see us be able to set reasonable goals and aspirations for people with this kind of a serious mental health condition, and see them aspire to those goals and achievement, versus this model that unfortunately we grew up with, which is there was no hope. This wasn't going to happen. This was going to be chronic. Marathon is different from chronic because there's still finishing lines there. What I would say about that, though, I think at bottom is this, that from the start, I think it's important for people to have support, and for us to give families support, not to criticize the decisions they make, and not to criticize the decisions that their loved ones who are living with this condition make. Because the reality is that most of the bad choices that were made for my Tim, and I suspect most of the bad choices that were made for Chris's Tim, were choices not made by them, but made in response to natural manifestations of what is simply an illness that they have that should just be treated as such, and mitigated as such, and allow them to move on pathways to recovery as best they can. And, that's kind of what I'd be looking for. Pushy, boy, that's saying it mildly. If all Chrissa was pushy, then most of the people I dealt with would have loved to deal with her instead of me during the process.
A doctor asked my husband if I was a nurse, and my husband said, no, she's a bulldog.
Fair enough.
Isla, there are, obviously policy issues that go into the mental health landscape, and whether it's health coverage or other things. The RAISE Act a few years ago. What policy issues should we really be aware of right now? Is health coverage particularly a problem? Is it something else? Are there issues or legislation that someone's working on that we should be aware of?
So I am admittedly not on our policy team, so I don't want to speak specifically to any sort of pieces of legislature, but I think the idea around the transition from how organizations and community behavioral health organizations are paid, transitioning from are they paid per individual versus more value-based payments, being paid for the type of care that they give, I know is a large chunk of many of our policy conversations. If you don't mind, if I could speak to what Carissa and Paul were just saying a minute ago about caregivers. I think about the last 10 or 15 years or so of being a clinician and working with so many families. And I think about the single, if I had to say the single greatest indicator from my perspective of someone's prognosis is the amount of support that they have in their life and the people that love and care for them. So for the caregivers who are listening, and for Paul and for Carissa, don't give up and be a bulldog. That there's such an immense difference in the individuals that I work with, of children who have a parent who is, or a caregiver who is immensely involved and is an advocate, versus the alternative, and the outcomes are astounding. I know this is only my personal perspective, but I think if there are many other social workers who would agree, just absolutely do not give up. And it's just so impressive, and it's draining, and I cannot fathom how difficult it is, but it's inspiring.
Thanks. I had one policy thing I wanted to bring up, though.
Go ahead, Carissa.
Sorry, I just want one policy thing I wanted to bring up, especially in terms of children. And thank you, Ayla, that was really sweet. Is that one of the things we benefited from when Tim was younger in the state of Illinois from a policy perspective is a program called the Individual Care Grant. So Illinois has passed 2 different laws to help families with children with severe mental illness. The Individual Care Grant was passed in the 60s, believe it or not. And what it does is it pays for community-based or residential services, treatment services for children diagnosed with a psychotic disorder, some kind of psychosis. And it is not dependent on the parent income, which is great, because unlike Social Security disability benefits, or, even, you can go through the Katie Beckett waiver, and we can talk all about that as far as getting help. What this does in Illinois is it takes, my son was able to go to a residential treatment facility that if I had to pay cash for it would have cost my entire income plus every single year. And that's, even though I'm not, I'm definitely middle class, it's not fair that we wouldn't have been able to get the treatment for him because of the prohibitive expense. And I will say a lot of insurance companies still, even though they would put you in a rehab facility or some kind of facility to help you after a chronic illness or a long-standing illness, most of them will not pay for a residential treatment for mental illness. So that's a policy issue I think needs to be addressed. The second one is that Illinois has passed a law that families are absolutely not required to relinquish their parental rights to their children to the state in order to get help from social services. That's not the case in the other 49 states in the country. Most parents with children with severe mental illness have either they've got DCFS on speed dial because they get reported so many times, or they've actually had to relinquish their children in order to get them the treatment. So imagine your child is diagnosed with leukemia and they say, we could absolutely treat your child, but you have to give your child up in order to get them treatment. It's ridiculous. I can't tell you how many parents I work with that have literally, they had to choose between keeping their child or their child dying. Those were their choices. And I think that's just absolutely appalling. And that's the thing I think we really need to address right now. Like I said, it's at the state level, but it's a huge issue as far as early intervention goes. Trust me, by the time you get to the point of relinquishing your child, it's not early. It's late.
You know, I don't think we could have had 3 better presenters and participants for today's conversation. So I just have to say a tremendous thank you to Paul, to Carissa, and to Isla for participating and sharing their expertise and wisdom with us today. We are going to close, but I'm actually going to close with echoing the point that Isla made, which is just so true. That strong family engagement is just so tied to better health outcomes for your loved one with schizophrenia. And, you know, it's a thankless task. And no one really ever gets a chance to stop and say thank you for what you do. But let us say thank you to those of you who are caring for someone with schizophrenia, and really to give yourself credit for doing the best you can in one of the absolute toughest jobs there is. There's no question that the challenge is that great. But I think we've figured out in these 90 minutes that family engagement makes all the difference, and that earlier engagement genuinely can translate into bigger benefits. We are going to bring up again on the screen some of the websites that we mentioned during the course of this webinar, so that you'll be able to go to those resources as well. And indeed, this webinar, which was recorded, will be available for people to see, and will be posted on caregiveraction.org in the future so that people can use it on demand. We certainly hope that you have found this helpful as a family caregiver, and thank you for being with us for today's theme of schizophrenia and families, earlier engagement, bigger benefits. With that, thank you, and we'll show you the resources. Thank you all.